Today we're honored to have a very special speaker. But first, we'll have our Dean of Medicine, Dr. Santiago Borrero, give us a short welcome. Quickly, we're recording this session, so when we get to the question and comment session, please, the audience who wants to make questions and comments, please use the microphones on both sides because we need that in order to make the recording, okay? Dr. Santiago Borrero, Dean of Medicine.
Buenos días a todos. Voy a tener el placer de dar inicio a esta actividad que es de gran interés para todos. Voy a pasar mi presentación breve, como va a ser una introducción breve, a inglés, de tal forma de que podamos asegurar de que nuestros visitantes entienden y escuchan lo que estamos diciendo. Good morning, ladies and gentlemen. I would like to welcome you all to this activity, which is very important for us at the Medical Sciences Campus. Welcome you all to this, the 52nd Bailey K. Ashford Annual Memorial Lecture. With this lecture, we want to acknowledge the significant scientific contribution of Dr. Bailey K. Ashford in the health sciences in Puerto Rico and worldwide. This annual lecture prestige is certainly confirmed by the reputation of their lecturers and participants, who have included Nobel laureates, distinguished researchers, professors, deans, and other presenters. Today, we are honored by the presence of Dr. James M. Hughes, a highly distinguished scientist, recognized worldwide. We want to invite Dr. Miranda, Associate Dean of Biomedical Sciences in our School of Medicine, to introduce Dr. James Hughes in this, our 2012 Bailey K. Ashford activity. Dr. Miranda, please come in.
Well, good morning, everybody. Dr. Hughes received his bachelor's degree and MD from Stanford University and completed 3 postgraduate training, one in internal medicine at the University of Washington, another one in the Infectious Disease Division at the University of Virginia, and preventive medicine at the CDC in Atlanta. Dr. Hughes first joined the CDC as an officer in the Epidemic Intelligence Service in 1973. Then he served as director of the CDC Hospital Infections Program. In 1988, he was appointed Deputy Director of the Center for Infectious Diseases and Center for Disease Control, and in 1992, Director of the National Center for Infectious Diseases until 2005, when Dr. Hughes joined Emory University, holding joint appointments in the School of Medicine and at the Rollins School of Public Health. Indeed, his scientific careers and achievements are supported by numerous and well-known grants, as well as an impressive series of scientific publications. Actually, he has published over 100 peer-reviewed articles, 15 editorials, and he is the author of over 45 book chapters in the field of infectious disease. He is the recipient of many honors in recognition of his academic contributions. These include the Distinguished and Meritorious Service Medals and the Surgeon General Exemplary Service Award from the United States Public Health Services. In addition, he received the CDC Lifetime Scientific Public Health Service Award in recognition of Dr. Hughes' achievement. Actually, this is just 2 or 3 that I mentioned from over, 30, 40, 50 awards I've received through his lifetime. For his contribution in the field of infectious diseases, he participated in over 200 presentations in the United States and around the world. And for his extensive knowledge in the field, Dr. Hughes participated as an international consultant in over 30 countries and in many advisory boards around the world. For his leadership, He participated in several congressional hearings and was elected president of the Infectious Disease Society of America in 2010. Certainly, his prolific career supports his dedication to the field of infectious disease. Dr. Hughes' curriculum vitae portrays many years of service and scientific contribution to this field. So, this is just a brief summary of an extensive CV that I just received from him. We are certainly honored by the presence of this distinguished clinician and scientist. Today, Dr. Hughes will share with us his knowledge and vision in the lecture entitled Emerging Microbial Threats, Issues, Challenges, and Opportunities at the Human-Animal Ecosystem Interface. Please let us welcome our distinguished speaker, Dr. James Hughes.
Buenos dias. Thank you very much to the Dean and to Dr. Miranda for very generous, overly generous comments in the introduction, I must say. It really is a pleasure for me to be back in San Juan. I had the opportunity over the years to visit the dengue branch a number of times, but have not been back for 8 years or so. So it's a particular pleasure to be here. It's very nice to see a number of friends and former colleagues in the audience as well. So what I'll be doing is trying to share with you a bit of the experiences that I had over the years at CDC and some of the areas of interest that I've continued to follow since moving to Emory University. And the title is Emerging Microbial Threats, Issues, Challenges, and Opportunities at the Human-Animal Ecosystem Interface. I have nothing to disclose in relation to this presentation. I wanted to take another moment here at the beginning to recognize the tremendous contributions that Colonel Bailey K. Ashford made to the health of people here in Puerto Rico and indeed around the world with his seminal discovery of the relationship of hookworm infection to severe anemia. And I know that he's deservedly highly revered here. I also feel very, very honored to follow in the footsteps of the many previous very distinguished Ashford lecturers. So just a quick outline of what I'll be talking to you about. We'll talk a little bit about factors that contribute to infectious disease emergence and spread, discuss some recent examples of disease emergence from animal reservoirs, describe challenges in zoonotic disease detection and response, and review some of the current efforts that are ongoing to strengthen the global capacity for early detection, response, and control of emerging infections. Before we get into the emerging infections arena, I wanted to use this slide that shows the crude death rate for infectious diseases in the United States from 1900 through 1996. The death rate shown over here on the left by year. And what you can see is the dramatic reduction in infectious disease mortality that occurred throughout most of the 20th century with one major disruption, obviously the tremendous surge in mortality associated with the first of the 3 influenza pandemics that occurred in the 20th century, the so-called Spanish flu. But following that, you can see the progress that was made along about here. Penicillin was introduced, Salk vaccine for polio, passage in the U.S. of the Vaccination Assistance Act contributed to the dramatic reductions in infectious disease mortality. But notice here, beginning in 1980, beginning in about 1980, there was a slow rise in infectious disease mortality, and that won't surprise you because you would anticipate seeing something like that because of AIDS. But in addition to that, bloodstream infection and pneumonia mortality rates increased during that period as well. Because of the progress that was made, there was the occurrence of a good bit of complacency about infectious diseases in terms of them having been largely controlled in the U.S. and much of the developed world. A good example of that complacency is illustrated by this quotation from Sir Macfarlane Burnet, a Nobel laureate who wrote back in 1962, "One can think of the middle of the 20th century as the end of one of the most important social revolutions in history, the virtual elimination of the infectious disease as a significant factor in social life." In 1992, the Institute of Medicine issued a very important report that drew attention to this concept of emerging infectious diseases. This report was the work of a consensus committee that was co-chaired by Dr. Joshua Lederberg and Dr. Bob Shope. Dr. Shope is a very distinguished colleague in the field of tropical medicine who I'm sure many of you know. This report was important in a number of ways. One was the definition that it provided of this concept of emerging infections as new re-emerging or drug-resistant infections whose incidence in humans has increased within the past 2 decades or whose incidence threatens to increase in the near future. Notice it's an extremely broad definition, and also notice that it includes the concept of drug resistance. That's a very important issue today. I'm not going to be focusing on it. I'll allude to it very briefly later on in the talk. This is my version of many similar slides that you've probably seen that illustrate a number of examples of emerging and re-emerging infectious diseases over the past 20 or 25 years. I'm sure all of you can see one or more of your favorites on there. The ones that are highlighted with the black background are ones that have occurred relatively frequently, and Hal, I'm sure you're noticing dengue in South Florida as one of those examples. But there are many. They share some features in common. The majority of them are either vector-borne or zoonotic diseases, and many of them have additional challenges associated with antimicrobial resistance. They also have begun all over the world. The 1992 IOM committee on the left identified 6 factors that they felt contributed to disease emergence and reemergence. Changes in human demographics and behavior, advances in technology and industry, economic development and changes in land use patterns, international travel and commerce, the incredible increase in movement of people, commodities, foodstuffs, animals around the globe. Microbial adaptation and change, the factor that makes infectious diseases unique and especially interesting as well as especially challenging. And then finally, and very importantly, as a result of the complacency that we have highlighted, the breakdown of public health measures with decreased funding going into issues related to prevention and control of infectious diseases in much of the developed world back at that time. In 2003, the Institute of Medicine convened a follow-on committee to assess project and progress and current challenges in this area. That committee was co-chaired again by Dr. Joshua Lederberg. Unfortunately, Dr. Shope was ill and unable to participate at that time. So Dr. Peggy Hamburg, who's currently Commissioner of the Food and Drug Administration in the U.S., co-chaired the 2003 committee with Dr. Lederberg. The committee validated the initial 6 factors and added 7 more in our increasingly complex world. Increases in human susceptibility to infection, changes in climate and weather, changing ecosystems, poverty and social inequality, war and famine, lack of political will, and sadly in the post-9/11 era, the intent to harm. I'm going to use now a few slides just to illustrate visually a few of these factors. First, human demographics and behavior. You'll see there on the left a scene that could have been a picture that could have been taken in a number of Asian mega cities. This happens to be Dhaka, Bangladesh. Here's a live or wet animal market in Southeast Asia, and here's a contaminated surface water source in a rural setting in sub-Saharan Africa, all of these being factors predisposing to infectious diseases. In terms of trends in global population, you all know that the estimates of the population of the world passed 7 billion within the past year. But this slide shows the population growth in more developed countries shown in blue and less developed countries shown in green. So it's easy to see where the vast majority of this population increase has occurred. Dhaka is one of today's mega cities. These are defined as urban agglomerations of people where 10 million or more live in a single dense geographic setting. In 1950, there were only 2 of these, both in the developed world. In 1975, there was one more, one of which was in the developing world. But by 2007, there were 19, 3/4 in the developing world, and by 2025, estimates of 27 or more of such mega cities, nearly 80% of which will be located in the developing world. As a result of this population growth, world meat consumption has increased rather dramatically, and projections show it continuing to increase. It's been relatively stable in the developed world, but it has increased rapidly in the developing world. So you can imagine, as the demand for meat increases, and particularly in these urban megacities in the developing world, the potential for contact between humans and animals, both wild and domestic, has increased dramatically and likely will continue to do so. And that obviously ties into the zoonotic disease theme of the talk. International travel and commerce. Here's a snapshot that was published a few years ago of global aviation travel over a 24-hour period. So as you all know and appreciate, we live in a highly interconnected world. This is moving primarily people. One slide you may not have seen an example of is a snapshot at one moment in time of surface vessels and their location around the world. Now, these ships are carrying some people, but lots of animals, lots of foodstuffs, and lots of other commodities. And these play a role also in movement of microorganisms and infectious diseases. Now, microbial adaptation and change, again, I've alluded to the importance of drug resistance. We see it in bacteria, we see it in viruses, we see it in parasites and protozoa, and we see it in fungi. So it's a problem across the board. Dr. Miranda mentioned my role with the Infectious Diseases Society of America. One of the big priorities for the society has been highlighting the need for renewed vigor and energy in the development of new antimicrobial agents, illustrated by the Bad Bugs, No Drugs initiative and the 10 by 20 initiative here. I would say there's been some progress, but lots and lots of work to do. Obviously, control of drug resistance requires much more than new drugs, but new drugs are an important piece of the overall strategy. Poverty and social inequality contributes to this problem in a major way. The picture on the upper left is from pre-earthquake Haiti, on the lower left from a peri-urban slum in Mumbai, and on the right, a picture of one of the favelas in Rio. Lack of political will, very important. You all, I'm sure, have followed the efforts globally to eradicate polio. There's recently been a historic achievement with the elimination now of endemic polio transmission in India, which for many recent years had been a hotbed of polio transmission. Challenges remain in three countries: Nigeria, Pakistan, and Afghanistan. And one of the complications of the polio eradication effort, a major complication, occurred back in 2004 when in northern Nigeria the decision was made to discontinue polio vaccine administration. As a result of that, polio spread to more than 20 countries as far away as Indonesia that had previously eradicated circulation of wild polio virus, and there's still efforts today to continue to take care of the polio in a number of these countries, as well as the three endemic countries. Another dramatic example is the lack of political will we saw with an important zoonotic disease, the experience with SARS. And you all probably remember, I and my colleagues at CDC and at WHO certainly vividly remember the story of the beginning of SARS. There were reports as early as mid-November of 2002 of the occurrence of severe cases of pneumonia occurring in residents in a couple of locations in Guangdong province in South China. There were efforts made in China to identify the etiology. They at one point thought that this might be caused by chlamydiophila pneumoniae. It turned out not to be true, but there was very little international appreciation of the magnitude and severity of what was going on. Following a report of a rumor on ProMed Mail on February the 10th of 2003, the next day China did report the occurrence of 305 cases of an acute respiratory syndrome in Guangdong province with a high mortality rate. At CDC and at WHO, when you hear that sort of thing, your first concern obviously is this might be a new strain of influenza. And then moving on with this story, this slide highlights the experience of one of the real heroes in confronting SARS, and that is Dr. Carlo Urbani, who was president of the Italian chapter of Doctors Without Borders. He was working at the French hospital in Hanoi in Vietnam early in March of 2003 when he was called to evaluate a severely ill American businessman who had, quote, a bad case of influenza. He learned that the patient had recently been in Hong Kong and had stayed at the so-called Hotel M. Dr. Urbani realized that the patient didn't have flu, but probably had something that was highly contagious. He notified WHO, and an investigation began. In addition, he took very aggressive efforts to ensure that the patient was properly isolated and cared for in Vietnam. Unfortunately, a few weeks later, Dr. Urbani developed shortness of breath, fever, myalgias, thrombocytopenia, and leukopenia, and was hospitalized in Bangkok. And the pictures on the top are his chest x-rays in which you can see the relentless progression of this pneumonic process that he had. Over the course of nearly 3 weeks, his fever persisted, his respiratory distress increased, and he died on day 19 of his illness. In fact, it was a lung specimen from him that was sent to CDC and was the source of the CDC initial isolate of the SARS coronavirus, occurring at a time that the virus was also isolated in several other laboratories around the world. This slide gives you a sense of some of the pathology associated with SARS. Now, remember, this was a previously unrecognized coronavirus. Pathologic studies included negative studies for flu, paraflu, rhinoviruses, mycoplasma. But cytopathic effect was observed on day 5 in 2 cell lines. And electron microscopic analysis of the supernatant cells showed a coronavirus. You can see on the lower left here the diffuse alveolar damage in the lung and a multinucleated giant cell in the middle. Now, here is an electron micrograph of SARS coronavirus, and you can see the crown-like effect around the periphery of the cell from which the name coronavirus comes. Now, at the time that this was identified, there were only 2 coronaviruses that were recognized to cause disease in humans, and they were in antigenic group 2, shown here, and they caused, in both cases, mild respiratory illness, and in one case also a gastrointestinal syndrome that was mild. So these had not gotten much experience from physicians, or much focus from physicians and researchers. However, on the veterinary side, how many people in the room have a veterinary degree, just out of curiosity? I'm not expecting to see very many hands. And here's a dramatic example. I don't see any hands. That's never happened. All right. We'll come back to that theme. But you can see the other 2 antigenic groups of coronaviruses, group 1 and group 3, that caused severe disease in a variety of human hosts or of animal hosts, primarily either respiratory syndromes or enteric syndromes. So the vets knew a heck of a lot more about coronaviruses than we did. Now, here's the most dramatic event that I witnessed in my many years of CDC. And this is the event that was responsible for much of the rapid global spread of SARS in late February and early March of 2003. A physician from South China who had been caring for patients with this severe unexplained illness, you remember, went with his wife to Hong Kong to attend a family wedding. When he arrived in Hong Kong on late in the afternoon of a day in February, he was not feeling well. He went straight to his room. He stayed there for 24 hours, by which time he was feeling much, much worse. And he was taken to and admitted to a local hospital where he urged people to take infection control precautions because he was concerned he might have this syndrome. He was in the hotel for 24 hours, reportedly never left his room. So he transited lobby to 9th floor. You may have heard this story. Ironically, he stayed in room 911. So you can imagine what went through our minds when we heard that. He came down the elevator and went off to the hospital. But somehow, while he was in the hospital, in the hotel, he managed to infect more than 10 other guests at the hotel, no staff. And you can see them in the letters around the circle. And then, of course, they went on their merry way and became ill in different locations and were admitted to multiple hospitals in Hong Kong, Vietnam, the case that Dr. Urbani cared for, Singapore, the U.S., Ireland, and Canada. And many of these countries had a dramatic experience with SARS. As a result of that, we were relatively fortunate in the United States. But you know about the spread to healthcare workers and family members in particular, and the epidemic that resulted in over 8,000 deaths in much of the world. Now, this turned out to be a zoonotic disease. In the early days of the investigation, there were links established particularly to this exotic animal, Himalayan palm civet, which exists in South China, is found in these live animal markets, and is a popular local dietary item. This is another rendition of a live animal market here. 2 other animals that had evidence of infection with this virus were Chinese ferret badgers and raccoon dogs. We don't recommend any of these as pets. Further investigation revealed that, in fact, these animals, which did not become ill as a result of their infection, were not the reservoir in nature, and the reservoir appears to be Chinese horseshoe bats. Bats will be another recurrent theme in the rest of the talk. Many lessons from SARS. This is a quote from a paper by David Heyman and Ganel Rodier, who led the WHO effort to confront this crisis. The SARS experience made one lesson clear early in its course: adequate surveillance and response capacity in a single country can endanger national populations and the public health security of the entire world. One other point I want to make at this point, and Dr. Urbani tragically, again, was a hero of this, but he was a public health official working for WHO as well as a clinician. So he was a frontline healthcare worker, and he played the pivotal role that I described in recognizing the severity of this issue and calling it to the attention of the global community. It's useful to reflect upon a lot of the new and emerging diseases that have been identified over the years, and in thinking about how they're originally picked up. By and large, it's been alert frontline health workers, physicians, veterinarians, nurses, microbiologists, pathologists. So, you know, we talk about large investments in very sophisticated electronic systems, but I always like to remind clinically oriented audiences that at the end of the day, it has been, and I suspect will continue to be, primarily the alert health worker who plays an important role in early recognition of these. I'm not going to read these to you, but this is a partial list of examples where the alert healthcare worker recognized initially the disease. And I think, Hal, my reading of the dengue in South Florida, the clinicians were pretty involved in the recognition there as well. Now, here's another strange illness rearing its ugly head on U.S. soil. This is a story that may be a little less familiar than the SARS story to many of you. One of the features associated with this is odd behavior, confusion, and a strange belief that prairie dogs make good pets. This is the monkeypox experience. Monkeypox is an orthopox virus. It was first identified in non-human primates, but its reservoir in Central Africa actually is in rodents. The first human illness was identified in 1970 in the Congo during the smallpox eradication era. It has clinical features similar to smallpox, and you'll see a picture of some of the lesions here in a minute to reinforce that. It has, fortunately, a lower mortality, less than 10%, less efficient person-to-person transmission than smallpox had. Prior to the occurrence of this dramatic event, all previous disease had been identified in West and Central Africa. There are actually two monkeypox strains, one in West Africa, one in Central Africa. The West African one causes less severe disease. It's been highly understudied until recently. It's begun to change a little bit. Smallpox vaccine appears to have been cross-protective, but of course it's no longer used, so that feature is no longer relevant in endemic areas. So one of the early cases in the monkeypox outbreak in the U.S. involved a 30-year-old woman who developed a sore throat, headache, fever, malaise, and a small painless papular bump on her left cheek. Within 48 hours, she had a sore throat, and her malaise worsened, and additional lesions developed, and you can see some of the lesions there on her palm at the top, and some of the pathology at the bottom. This is a picture from a child with one of these early infections who you can see the primary inoculation site there on top, and in the child's index finger where it happened. She had been bitten by a pet prairie dog. And here are some of the pox-like lesions on the hand. Now, autopsy studies were done on prairie dogs, and this picture here on the upper left of prairie dog tongue of an infected animal, you may be able to appreciate only that there's an ulcer there. And here it is at the bottom with immunohistochemical staining for viral antigen, and you can see that there's lots of monkeypox antigen present in the tongue. And then some of these animals went on to develop pneumonia where they had viral antigen demonstrable in lung. So one of the reports from the friendly media, officials scramble to contain monkeypox. It was a particular scramble because it was new, it was the first time, and it occurred in June of 2003 while we were still dealing with that little problem of Sars at CDC and in state and local health departments around the country. Here on the, well, to stick to the epidemic for a minute, this is one of the famous prairie dogs associated with this. This is Chuckles. Chuckles was the source of the infection in this child who recovered, and Chuckles actually survived his illness as well. Now here's a dramatic illustration of high-risk behavior. I'm sure you don't have prairie dogs in Puerto Rico, and I'm hoping you don't have any people that have prairie dogs as pets here. But if you go and visit the western United States, where you'll run into potentially plenty of prairie dogs, don't do this. And monkeypox is only one of the things you might conceivably get if you did. Okay, so here's the story in terms of what happened and how this was introduced. There was a large rodent shipment from Accra in Ghana in West Africa that in early April of 2003 went, according to regulations, to a quarantine holding facility in Texas. This shipment included lots of exotic critters, most notably giant Gambian rats and dormice. So these were rodents. There were also squirrels, porcupines involved in the shipment, but a number of exotic animals that were brought in because of the interest of the exotic pet trade. So they served their quarantine period, were not ill, and then were shipped to a number of different facilities, in two of which were, or three of which, I guess, or four of which were actually in Texas, but also to a facility in New Jersey, and very importantly to a facility in Iowa. Now watch that one, because that's the significant one, shown in red. That shipment included only the giant Gambian rats and dormice. So they went from there out to a number of other states, a facility in Illinois on the bottom, and then to Minnesota and on to Wisconsin, and a shipment that went to Illinois 1, shown in the red. This is the important one. Both the giant rats and the dormice went there, where they met for the first time 200 prairie dogs that were in this facility as well. Well, I think you're beginning to get the picture of what happened. We'll show you a little bit more about that facility in a minute. But as a result, after these prairie dogs had the exposure to the giant Gambian rats, which appeared to be the source of this, they were then shipped out to a number of other facilities, and they were sent to pet shops, and they were sent to a number of these events that occur that are called swap meets, where people come in and bring pets that they have either to exchange or to acquire new ones. And so there were a number of states involved. There were a number of cases, a little over 70 in total, of human infection. Fortunately, only 2 moderately serious illnesses and no deaths. And no escape of any of these prairie dogs into the wild to introduce the infection into the wild U.S. prairie dog population. One thing you might not have appreciated, one of the other shipments actually resulted in some of the animals being shipped on to Japan. So Japanese authorities were notified this was not one implicated in transmission, and there was no introduction of monkeypox into Japan. But this gives you a flavor of what happened. Now this is the prairie dog equivalent of the Hotel M in Hong Kong. This is a holding facility in a garage, here it is, associated with this house in suburban Chicago. And this cute little guy is a giant Gambian rat, and here's a dormouse. So there is a huge annual global trade in exotic animals, some of which is legal, some of which is illegal. The legal trade can be as much as 4 million birds, 640,000 reptiles, 40,000 non-human primates, and the magnitude of the illegal trade is unknown, but certainly involves, among other things, bushmeat from non-human primates that you may have heard about as a problem of particular concern. So again, back to the important role of the Vigilant healthcare provider. It was physicians in Wisconsin who really initially recognized this monkeypox event. But the important role that alert physicians, veterinarians, pathologists, laboratorians, research scientists, and public health officials play in the recognition of these things, which can be associated with some pretty dramatic surprises, such as transplants associated with transplant-acquired rabies and transplant-acquired West Nile disease. So I think you all know, and it's important to remember, that AIDS initially was a zoonotic disease as well. So a quote from an article in Lancet ID: tracing the origin of HIV has confirmed that viruses can jump from one species to another after a very long period of no transmission and adapt abruptly. So this arena of zoonotic infectious diseases has gotten increasing attention from the public health and the research community, I think rightly so, in recent years. Here's a diagram from a paper published by Nathan Wolfe and colleagues in Clinical Infectious Diseases, in which he proposes 5 stages to describe how pathogens of animals evolved to cause diseases confined to humans. And you can see the pathogens over here on the left and some features associated with the 5 stages on the right. The first stage being the infections remaining confined to animals, and foot and mouth disease being an example of that. In stage 2, West Nile virus and Hendra virus are examples where the experience has involved primary human infections only. Ebola and monkeypox have been associated with limited human-to-human transmission at stage 3. Influenza A obviously was sustained human-to-human transmission. And then finally HIV, which now is exclusively confined to humans. A couple of recent reviews of this problem of emerging pathogens have resulted in what's shown on this slide and the one and again on the next slide. Systematic literature review identifying 1,399 human pathogens, 87 of which, or 6%, had been reported since 1980. 2/3 were viruses, mostly RNA viruses. This occurred globally, and the majority resulted from transmission from animal reservoirs. A more recent review by Kate Jones and Peter Dosick and others that appeared in Nature, review of 335 emerging disease events from 1940 to 2004. They noted a global distribution, but it was non-random. In other words, there were hotspots that this review identified. 60% of these resulted from animal reservoirs, and very importantly, 72%, nearly 3/4 of those, resulted from wildlife. And then the hotspots that I mentioned. Now, some of these events have resulted in incredibly high economic impact and direct and indirect costs. And you can see some of the examples depicted here, and the size of the circle give you a sense of the relative magnitude of the cost. But you can see BSE and variant CJD in the UK here, foot and mouth disease in the UK here, SARS here, and H5N1 influenza. This slide doesn't include a big circle associated with the pandemic H1N1 experience more recently. So this brings me now, as we begin to approach the end, to a brief discussion of this interface between the human medical and the veterinary communities. This is a movement that's been called One Health, or the One Health Initiative, or the One World, One Health. It goes by a variety of different names. But the point here is that, as I hope I've convinced you, human and animal health are inextricably linked. They always have been, and they always will be. Here are a couple of the leaders who, back in the mid part of the 20th century, called the attention of colleagues and to some extent the public to this issue. Calvin Schwabe and UC Davis and Jim Steele, who's still alive, who is a long-serving public health service officer and chief of veterinary public health at CDC for many years, who highlighted long ago the importance of this issue. And this issue of One Health really focuses on the interface between humans, animals, both domestic animals and wildlife, for the reasons that I think I've explained, and then ecosystems. So this is where the ecologists and others that we don't traditionally collaborate a whole lot with come into play. There are a number of issues in this arena. There are the hot spots that I alluded to, that Dossick's work described. Rainforests and megacities come to mind. There are hot reservoirs, bats, pigs, and prairie dogs in particular. Hot settings such as these live animal or wet markets in Asia. Hot vectors such as the Asian tiger mosquito, which I was happy to learn this morning you still don't have here on the island. I hope that continues. And then hot vehicles such as bushmeat, as I mentioned. There's a lot of effort in this field to predict the occurrence of outbreaks, and efforts to discover agents in wildlife in particular that have not been previously recognized, that have the potential perhaps to cross species lines. There's another aspect to this problem, and it's the stigma associated with naming of new agents. This is a lesson that we learned over and over again, it seemed, at CDC. When you identify a new agent or a new disease, you have to be extremely careful what you call it, because once you call it something, that name tends to stick sometimes a lot longer than you wish it would. And it has stigmatized Navajo Indians, Haitians, Mexicans, Asians, and industries such as the pork industry. You can imagine if there were some pork or swine veterinarians in this room that they might not care for this name of swine flu that gets used. So the stigma is extremely important. It's a recurrent theme, and it's something that we all need to continue to be sensitive to and careful about. USAID has actually picked up on this, and they have an emerging pandemic threats program that includes a number of components, including projects called Predict, Respond, Prevent, and Identify. I'm peripherally involved in the one that UC Davis leads, that is the Predict project. But this is a wildlife surveillance project to detect potential human pathogens in wildlife long before they cross the species barrier. This was launched in FY 2010. It's a 5-year project. I serve on the advisory committee to this, and we're meeting in a couple of weeks to get a report on the progress here. But they've been very active in the Americas, in Asia, and in sub-Saharan Africa, in some of these hotspots. And part of the idea here is to move from over here, where a lot of these emerging infections are typically identified when humans seek medical care, as we've talked about, which follows not too long after symptoms develop in humans and exposure occurs in humans. But in some of these cases, at least, there is the potential to detect these events further upstream with ill animals or presence of these agents in wild animals in the absence of any disease. And ultimately, of course, what you'd really like to do is get even further back over here and address some of those root factors that we talked about at the beginning that contribute to endemic infectious diseases as well as new and emerging infectious diseases. So I'm not going to read this slide to you, but it illustrates the fact that there is a lot of potential common ground for medical and veterinary communities around these issues. The veterinarians have to deal with influenza, with exotic pets and wildlife trade, with foodborne disease, and the list goes on and on. They also have some significant and historical experience with disease eradication. You know about the eradication of smallpox. Some of you may not have heard about the recently declared eradication of a very important cattle disease known as rinderpest, the predecessor of measles virus. So the veterinary colleagues deserve tremendous credit for that achievement. So at CDC, I was often asked about what are the future challenges likely to be. Hard to predict, as we all know. Another flu pandemic, we just don't know, as usual, where, when, and what influenza virus will be involved, but we can be pretty sure there'll be another one. We're seeing more and more drug resistance with the potential to return in some cases to having untreatable infections such as occurred in the pre-antibiotic era. We can probably anticipate more international foodborne disease outbreaks. We're always concerned about the potential resurgence of urban yellow fever in the Americas and its potential introduction into Asia. We're going to be surprised again and again by the role that microbes play in chronic diseases. And we know that we have to continue to be prepared to confront the unexpected. Now, you know that shortly in the aftermath of SARS, H5N1 influenza infection in humans, which had first been appreciated in 1997 in Hong Kong with a small outbreak with a 33% mortality rate, began to be identified again in a number of Southeast Asian countries, resulting in severe human illnesses, roughly a 50% case fatality rate. Unfortunately, very limited human-to-human transmission, but this focused attention on H5N1 as being the likely source of the next influenza pandemic. Well, surprise, as so often happens. This is a very astute comment made by Ted Eickhoff, a distinguished infectious disease clinician, who wrote back in 2005, at the same time, I'm somewhat bemused by the number of experts who appear regularly in the public media and predict with virtual certainty that H5N1 will be the next pandemic strain, and soon. Lifelong students of this disease are much more humble about their predictions. So, amen to that. Beware that hubris thing. Okay, so 2003, the IOM committee said a robust public health system in its science, capacity, practice, and through its collaborations with clinical and veterinary medicine, academia, industry, and other public and private partners is the best defense against any microbial threat. Now, I'm not going to take the time. I know we're at the end of the hour here, so I'm going to skip over the next couple of slides. I simply want to call your attention to the fact that there are new international health regulations in place issued by WHO in 2005, went into effect in 2007. Took them about 11 years to make this happen, to replace the old, highly outdated international health regulations that were issued back in 1969. The goal here is to prevent the international spread of disease using the least disruptive methods possible. But it calls for a dramatic increase in surveillance and response capacities in countries around the world. And if you're interested in this, you can go to the WHO website and get a look at this for much, much more detail. But it calls only for the immediate notification of a single case of just one of 4 diseases. Smallpox, not currently an issue, hopefully. Polio, SARS, not currently an issue, and certainly influenza caused by new subtypes. And then it contains algorithms that tells you at the national level when one of these other diseases is detected, how one assesses whether or not it needs to be internationally reported. So lessons learned from all this and some of the future needs: vigilance, strengthened surveillance and public health lab capacity, better predictive capability, multidisciplinary partnerships, improved coordination, proactive communication, avoidance of stigmatization, transparency and sustained political will locally, nationally, regionally, and globally. And there remains a critical need to address research, training, and education priorities. So the trends of the factors that I described and others that I didn't, in general, favor the microbes. There will be new threats emerge. Many will be zoonotic. Vigilant frontline healthcare workers, as I mentioned, will continue to play a very important role. For the clinicians in the group, when you're dealing with an unexplained febrile illness, remember to get that travel, work, hobby, and animal contact history. Surveillance is critical to achieving public health security. Improving national and international surveillance capabilities should be priorities for national health and security policy. And helping individual countries improve their surveillance capacities will benefit all countries around the world. So expect the unexpected. Don't follow in the footsteps of Sir McFarland Burnett and others. Beware of that complacency. Beware of the hubris. And if you're interested in this stuff and you haven't seen it, CDC publishes one of my favorite journals, Emerging Infectious Diseases, that is available free and online through the CDC website. So last slide, just an acknowledgement of the number of people who provided some of the slides that I used. So thanks very much. It's 12 o'clock, so I'm happy to take a few questions if there's time, or stay around down here if people want to talk. But thanks again very much for the honor to be here and for your attention. Now, if there's time, we've been asked to urge you, because the session's being recorded, to use the microphones on the side. If you're stuck right in the middle, I can try and repeat the question. Jose.
Hi, Jim. Great presentation, and thank you. I just wanted to see if we could spend a couple more minutes on the Monkeypox Experience. I was so impressed on that picture of the holding place that looked more like a mom-and-pop shop than a well-guarded and cared area. Because of the monkeypox, was there any change in terms of U.S. or local regulations in terms of testing for monkeypox and of animals that come at least through the legal trade? It's really hard on those that are in legal trade.
Right. Well, let me clarify one thing and then say a little bit about what's happened, and also admit that since I left CDC, I haven't followed all the control activity real closely. But a couple of things have happened. First of all, at the origin here, those animals at the time, they were brought legally into the U.S. and they went into a reasonable holding facility and were held for the recommended period of time. So at the front end, it was okay. The animals were not affected by the virus, so they had no evidence of illness. And then off they were shipped. And that's where the regulatory authorities, it's my sense that breaks down. I'm not sure who, if anyone, had ever been to the holding facility outside Chicago that I showed you the picture of, and you got the sense of what that was like. That was a suburban community with houses all around, and this was being done in a garage. I'm not quite sure what the neighbors thought of all that. One positive thing that has happened is these exotic rodents from West Africa or Central Africa are no longer permitted to come in legally into the country. We were extremely concerned that if some of these animals had gotten out or had been released, with their infections, they could have introduced the virus into resident prairie dogs in the wild, and you can imagine what might have happened from that. So the regulations have been changed. Those animals are not coming in. The other important thing that I alluded to was we were lucky. These were critters from West Africa, where it's a second strain of the virus that causes less severe disease in humans. The Central African strain, has a 10% mortality rate. So we were lucky that that was not the source. So that's as far as I can go with the nitty-gritty of what
Thank you so much.
Current status is. Yes.
I appreciate very much and I enjoy your talk. I just want to make a comment. I work in AIDS research, and I think HIV really gave us an example of a very powerful virus, and also show us how many stigma we have with society, and really make us scientists to understand perhaps a little bit better the world and show how naked we are to respond. I think the bottom line of what, if I understand the message correctly, is that the bottom line of what's happening in emerging diseases is really poverty. Poverty, that is, the poor people. I mean, if this gap that we are having, and we, what you show, obviously, I come from Latin America, I understand that quite well. Around the world, the inequalities that exist are going to perpetrate, probably, this system. And no matter what we do as scientists, no matter what powerful, and beautifully, intended measurements, we want to do as scientists, if we don't change the political system that is operating in the world, we're going to drown with, this system. And that's a commentary.
Yes. Well, thank you. I think that's a very important and very relevant comment to this and other experiences in today's world. I hope that many of you, I wasn't here yesterday to hear Dr. Bill Fagey give his talk as part of this great meeting, but I understand that he talked about poverty as a critical issue. Now, that poverty was one of the 13 factors, as you saw. One other comment that I would, or a couple of other comments I would make. One is, if you look at any individual dramatic example of disease emergence, it's not a single factor that contributes. It's a multiplicity of factors that contribute to the emergence of each of these diseases that I've referenced. But if you ask me what probably the two most important ones are at the root, it's poverty and, not unrelated, lack of political will. And so it's yet another reason for all of us to be concerned about the global situation, and whenever we have a chance to advocate and educate policymakers about the importance of this, and that these no longer can be thought of as simply problems over there. As we know, many of them show up over here as well, and it's in our best interest to try to address the issue everywhere. But again, this stigmatization thing is incredibly important, and probably with AIDS it was the most dramatic example. But we had an interesting experience anecdotally that I'll relate briefly, related when the experience when hantavirus pulmonary syndrome was recognized. That was back in 1993. Many of you may not know this story, but it was an alert clinician working on the Navajo reservation who took care initially of a very ill young woman with what could have been SARS. It was a severe acute respiratory syndrome. She died. Her fiancé, who collapsed at her funeral with an acute febrile respiratory illness, and also died. So this caused great consternation and concern. And it took a while in that case to identify the cause, which turned out to be this previously unrecognized hantavirus. But realized this was a disease that caused severe illness like SARS, but unlike SARS, it was transmitted much more easily from person to person and much earlier in the course of illness. One of the features of SARS was that people didn't transmit very efficiently until they'd been sick 5, 6, 7 days. And that's what ultimately allowed early case identification, isolation to work in terms of helping eliminate that disease. With the hantavirus experience, when the virus was isolated, I learned that the tradition, and many of you know this, when you get a new virus, in terms of nomenclature, you often try to name it after the site where the specimen came from. So unfortunately, the initial choice was a location on the Navajo reservation that was Holy Land. And you can imagine how that went over. First of all, the Navajo were already stigmatized because of the recognition on the reservation. And then, unfortunately, the initial decision was made to call this, I think it was Whitewater Canyon virus, but that's a revered holy site. So that didn't stick, fortunately, but it caused some awkward moments, as you might appreciate. Okay, so again, thanks for the very important comment.
I would like to call to the podium Dr. Santiago Borrero, Dean of the School of Medicine, Dr. Rafael Mercado, Chancellor of the Medical Science Campus, and Dr. Ilka Rios, Dean of Academic Affairs, to present a plaque to Dr. James Hughes for his contribution and dedication and excellent presentation in today's talk. Bueno, gracias.